Hello everybody, welcome to UroChannel. It's Friday evening, 8 o'clock Central European time, and it's time for my weekly live stream. I've been doing this since since the end of September last year. So far, I'm very thankful that many of you are joining this live stream every Friday, and I'm very happy that many of you are subscribers to UroChannel, and I think also some members of my above average membership. So if you haven't heard about it, there's a membership for on YouTube on UroChannel where you can join the above average members club, which means that you get a badge and you can support my work with $1.99 per month. Today I'm going to talk about a special approach that I have for erectile dysfunction, which is shockwaves, the P-Shot, and a novel form of treatment which is called EMTT. I've explained it in some of my videos, but maybe you haven't heard about it, so I wanted to take the chance to talk about it. And also, since I have gotten into the habit of updating you what is happening in my office and how are my results, do I see some progress, what is changing? And in case you haven't seen me, you're not a subscriber, not anybody who has watched UroChannel, my name is Dr. Stefan Buntrock. I'm a urologist and I'm practicing urology on a daily basis, and I see patients, and my specialty is in sexual medicine and sexual health. So if we just start with the treatment approach that I've been doing for the last, let's say, year, it's a combination of so-called regenerative therapies. So when erectile dysfunction sets in, that's usually due to changes that come about by aging. So when you have passed a certain age, then usually you undergo certain changes like hormonal changes, also that spontaneous erections decrease, nighttime erections decrease. As a result of that, you may develop some kind of muscle degeneration within the corpora of the penis, the corpora cavernosa. Then also you may develop some diseases like, for example, diabetes. Then hypertension is an erection killer. If you have smoked, this is not good for your blood vessels. This will also be detrimental to your erectile health. All these things come together, and then you may develop erectile dysfunction. If you do so, you're not alone, because this is something that is affecting a lot of men at a certain age. And if you will get 100 years of age, it's almost 100% erectile dysfunction. So we lose lots of men along the way into old age, and there are only a few men who retain their erectile function at the age of 70 or 75. So I get some comments on my theos of men above 70 telling me, okay, my erections are fine, but you guys are lucky because you are a few of the chosen who have not developed any erectile dysfunction. And as a rule of thumb, we say that 40% at the age of 40 have difficulties. And I'm not talking about complete erectile dysfunction, but certain erectile issues. So when this comes about, it develops gradually. It's not like this, then you have no erection anymore. So it's usually that the erection gets weaker. Often it doesn't sustain the whole time you want erections to happen. Sometimes you have difficulties getting an erection, and then the next time it's working fine again, and then again something's wrong, and you think maybe it's in my mind, which I have to say it is, because once you develop erectile problems, your security will suffer. So you're not self-secure of yourself that you can say, okay, when I want to, I can get and sustain an erection. And this is doing something to the psyche of people, that they're getting insecure. And this gets into a vicious circle where you may have more difficulties just because of the psychogenic things that will add up. But usually I would say, like, when you are maybe above 40 up to 65, 70, this is where rehabilitation of what has been lost to a certain degree or in toto may be possible. So without taking any drugs that you will have to take every time you want to have sex, but I mean something that's giving you a regeneration of what you have lost. So these are the so-called regenerative therapies. And as I said, for a year, I've been using a multiple approach because I have started with shockwaves when I opened my practice, when I opened my office. That was 8 years ago. So I opened officially in May 2017, but I kind of started when I was still doing some renovations to my office in January 2017. So I had a shockwave machine from day one, and I treated patients with shockwaves. Now, I know that many of you are watching from the US, and you have to know one thing, and you can't just stress this point enough. Shockwaves are a very special kind of wave that are applied to the penis and the corpora with an applicator. It's a handheld device that you put on it, and the whole shockwave machine is huge. So it comes on a trolley. It's a very huge machine, very bulky, and this is a medical class machine, so you wouldn't be able to buy it. It's just for doctors because you need some kind of license to be able to buy that kind of machine. And shockwaves are special waves that have certain characteristics, and these characteristics are that they travel through a given matter faster than the speed of sound would, because shockwaves are waves that are acoustic waves. They are not sound. They are acoustic waves, and they have the characteristics that they flood the cells very rapidly. This is in microseconds, and then it's so powerful that when they subside, that's even pulling the cells. So it's very much stress to the cells. It kind of damages the cells, or better to it provokes repair mechanisms, and this is what's the principle of shock waves. So it's very much stress to the cells in order to make them regenerate. And what's happening in shock waves is basically that it promotes the formation of new blood vessels. It restores nerve function. It promotes stem cell release. And these are the mechanisms. And what I see, what I think is not that much stressed in practice, and also when I read studies, is that it releases trigger points within the pelvic floor muscles. When the pelvic floor is tight, which is the case in many men with erectile dysfunction that I see, then there is a worse erectile ability. So when I loosen up the pelvic floor by shock waves, which is a side effect when I'm applying the treatment, then I immediately see that some are getting really much better by the shockwave treatment. Shockwaves don't do the work at once. It's the same with all of the regenerative therapies. They all need time. And it's not that you get a treatment and you go home and something's happening. It takes a couple of weeks. I would say maybe 6 weeks or so until you really feel a difference, what has been done. And shockwave treatment is effective. So we have data on shockwaves being effective for erectile dysfunction. And in our European guidelines from the European Association of Urology, shockwaves have a grade of recommendation that they may be applied for erectile dysfunction. This is not the case in the US. So the FDA hasn't yet approved shockwaves in the US. So what's being done is that you can get shockwaves in the States, but they are used on, like, for example, the shoulder or Achilles tendon, something like that, and not for men's health. This is one of the problems. What is approved, or what is done in the US, that's the big difference to what I'm doing, is that radial pressure waves are marketed under the label of shockwaves. But radial pressure waves are not shock waves. Radial pressure waves are compressed air. You have a cylinder, and then you accelerate a projectile within the cylinder, and this compresses the air, so you have a certain kind of wave that's coming out. That's likewise an acoustic wave. But this acoustic wave has totally different characteristics than shock waves. Are they effective? I don't know. There's some minor studies that suggest that they may be effective, but on the whole, we have no evidence to support this effect in a way that we have for real shock waves. So I wouldn't be able to answer that question. So I'm using real shock waves. And the question is, can you do these radial pressure waves at home? Yes, there are devices that you can buy online. I don't recommend them because this is not the real thing. It's not shock waves, and you can't, in my opinion, you can't expect to have the same kind of effect of a device that you buy for $150. That's this small compared to a huge machine that does all the trick. And these machines are very costly in maintenance. So maintenance for my shockwave machine costs like almost 10, like the small ones that you can buy on the internet. So there's a huge difference between medical devices and stuff that you can buy yourself. So I know some of you will say, well, you only wants to make money, but you can be assured you are far away, like thousands of kilometers away. So I'm not telling you this, so I want your money. But if you want to give me some money, you can join my memberships. So it's $1.99 per month. You just hit the button, join, and you can join my memberships. That would be very nice. Thanks a lot. So this is shockwaves, and there is some evidence, like if you apply shockwaves, you can maybe get 3 or 4 points in the International Index of Erectile Function. This is a questionnaire that you can take. It's 5 questions and 5 answers, and you can get a maximum of 5 points for every answer. So there's a maximum of 25 points. And if you score like 22 to 25, it's normal erectile function. Then it gets a little worse when you have between 19 and 21, and so on. So you take a baseline test, and then you can kind of calculate what are you supposed to get by shockwave treatment. And I was very satisfied with shockwaves, I have to say that. But I'm that kind of guy who I'm always wanting to improve. Always. So I'm never satisfied with what I have, and I think, well, maybe I can get it a little better. And this is when I started to integrate the P-Shot, which is platelet-rich plasma. Oh, by the way, shockwaves, no known side effects. I haven't seen any side effects. I have my 2nd generation machine now. It's another manufacturer. The first machine had a slightly different focal point that was very close to the surface of the applicator, and I could move the focal point by cranking up the machine, which is not the case with my new machine. With my new machine, I have a fixed focal point, and I adjust the focal length with spacers that I apply to the applicator, and that's the difference. So when I had the old machine and I really wanted to progress into the tissues, then there was a lot of energy at the surface, which led to slight bruising in some of the patients, but that was very minor. But this was about the only thing that I have seen with shockwaves so far. So no known side effects, and not in the literature either. Then there's PRP, which is platelet-rich plasma. It's very, I think it's very exciting, this technology. And this is not anything that's supported by any guideline right now. So the European guidelines that I'm a big fan of, they acknowledge that there is something like platelet-rich plasma for erectile dysfunction, but they say, guys, we don't have enough data to support that. Large scale data to make a recommendation, but we think this looks promising kind of, but we want to wait until we issue some kind of recommendation. So what this is, it's not any kind of drug. It's something that's from your own blood. So your own blood gets kind of worked on, and you get it back, parts of it, which is called PRP, which is platelet-rich plasma. So in your blood, there are certain cells, cellular components, and there's plasma, like it's the water, so to speak, where all these cells are swimming in. Then you have lots of red blood cells, you have white blood cells. Basically, you have some immune cells, so-called killer cells, and then you have platelets. And these are very small cells which contain a lot of growth factors. Platelets are for wound healing, for example. They do a lot of stuff and regulate lots of functions. And these platelets, when they release their contents into the periphery, they have a healing effect. So if you gather all your platelets in one spot, and then you inject them into the penis, the idea is that then you get a regenerative effect, almost in a sense like you would get from shockwaves, but it's a little bit differently. So this is marketed by the name of P-Shot, because P is for Priapus. Priapus is a Greek god, an ancient Greek god from the antiques, and the old the antique Greece people, inhabitants of Greece, they, when you look at the museums and you have a picture of Priapus, he has a big phallus, a large penis which is erected, and therefore it's called the P-shot. It's the Priapus shot. So this is like when I take it, like take 50 milliliters of blood. It adds up to 60 milliliters, and then what's left is 4 milliliters of PRP. That's what's coming down to, and this is re-injected into the penis. So the only thing that could happen with a P-shot, and that would be a catastrophe. That is it's a mistransfusion, so that you would get the P-shot or the blood plasma and all the components from somebody else. This would be a total catastrophe, and I'm very lucky that it can't happen in my office because there's only one patient at a time, and I'm doing it all by myself. So I'm taking the blood, I'm carrying it to the lab, I'm performing all the steps, and then I take it back to the patient. Nobody else is there. Takes 20 minutes, and then I have the product. So this is the only thing that could happen when you do the P-shot. Otherwise, it's your own blood, so you just get it back, and it wouldn't cause any harm in that respect. So I combined the P-shot with the ESWT, with the shockwaves, and that had an effect. And I could see kind of, okay, that was maybe better. And then from spring 2024, I integrated another component, which was EMTT. It's extracorporeal magnetotransduction therapy. That looks almost like a shockwave device, but these are not shockwaves which are coming out. It's the same frequency I have, so it's 8 hertz, which is 8 shocks per second. But what's coming out is electromagnetic energy. And this stuff is very powerful. So you don't really feel it on the penis, but I found out that it comes from orthopedics, so it's used in certain circumstances. And sometimes when I have some pain somewhere, like in the shoulders, I treat myself, And when you have something that's inflamed, like an inflamed tendon or so, it really hurts. It's a very yucky feeling, these magnetic waves. But if you don't have anything, you don't feel anything. So many patients, they think there's nothing coming out because they don't feel anything. But I guess it's the same with radiation. When you have ionizing radiation therapy for cancer, so you don't feel a thing either. So, but there's definitely coming out something from this, and this is very powerful. It's 80 milliteslas, which this one has. It's very much of energy. It's not comparable to MRI. MRI is much stronger, but 80 milliteslas for a handheld device, that's impressive, I have to say. And you have to remove everything that's nearby, like for example credit cards or smartphones. They would be erased by this. So you don't have, you're not supposed to have any keys in your pockets, stuff like that. So I combined these three, and I've been doing this for the whole summer, and I had a video that I uploaded, maybe you've seen it, of one of my patients, a 62-year-old man who came in with erectile problems, and he was treated with combination therapy, and I had this sensor. I've been showing this in one of my other videos. There's a sensor that you can buy online and can put it on your penis, and it records nighttime erections. So it records not only how long you have nighttime erections, it also records the quality of nighttime erections. And then it compares it to a cohort of men in your age group. So you would be able to see how old you are penis-wise, just judging from the erections that you have at night. I think this is very handy because I always ask my patients about nighttime erections, and not everybody knows about it because they never wake up and they wouldn't know whether they had nighttime erections or not. So unfortunately, they had some problems in sending him the sensor, so we don't have any baseline readings. But then after 6 weeks or so, 6 weeks, 8 weeks, he was testing after the treatment, and then he sent me the results, and they showed that his penile age had gotten down to age 26 from age 62. So he was very satisfied, and he wrote me an email, I think a couple of weeks ago, that the effect is still sustained. So this is well working in his condition. And then this is why I'm telling you this, a couple of days ago, I got some more feedback from this combination therapy, and I've been doing a slight change lately, that because there were some patients coming from far away, and they wouldn't be able to come twice to my office, twice a week for a certain number of weeks. So I tried to condense this treatment, and I did bulk treatment because there is some research out there suggesting that if you can like condense the whole treatment on 3 to 4 days, and then you would be able to maybe have the same effect. So I did that just out of practical reasons to see whether this was working, and it seems like this is working beautifully. So I get the last days I got some feedback from patients telling me, well, this has really improved. And even there was one patient, he has been struggling with erectile dysfunction for over 20 years, where this apparently hasn't gotten a lot better. And why do I believe that? Because they want to come back and take another course of treatment because they are so amazed what is happening. So the bottom line is, I think it is possible to regenerate the penis in a sense that it gets better. But I also have to say I have patients where this is not working. This is a minority, but sometimes these approaches wouldn't work in patients. And the question is why? And I think I've been touching upon this in the very beginning. The psyche plays a very huge role in these circumstances. So we must not forget there is something like also like placebo treatment when it comes to any kind of treatment. And in reality it's a psychogenic ED, or the psychogenic component is very large. You could almost do anything. If you believe this is going to help, then it probably will. So you could say, like, you could stand up at one leg, and then you could chew, I don't know, walnuts and count to 3, and then it helps. I don't know. But these effects are very powerful, and they are also effective. So in some patients, it doesn't work. And this is why I told you in the beginning, I think the best effects are to be seen maybe from age 40 to age 65, something, maybe age 70. But in the older age groups, I'm not quite sure, because then you have to see, like, if you go 75, maybe 80, there are a lot of changes that have happened because of the aging process. And the question is, will you be able to regenerate that? And for the time being, I wouldn't be able to give you an answer. I just feel in the patients that I've seen in these age groups that it's much harder, and maybe the effects are not that pronounced than in the younger age groups, because you can't regenerate it all. And there's one thing that's very important. It's about what you expect of the results. And I think maybe many men expect that they will have more sexual desire, but this has nothing to do with sexual desire, so you wouldn't have a gain in this. And likewise, most probably I wouldn't be able to restore erectile function in a, let's say, 60-year-old to where it was 26. So this was the exception. I was just telling you about this, what is maybe possible, but I wouldn't say that this is the norm, so that it's working in everyone. I think it's too early to say that. Maybe I will tell you within 2 years from now that, wow, this really helped in a lot of patients, and much more than I have expected. But for the time being, I'm reluctant to be too optimistic and too enthusiastic about this. But for the time being, it looks very promising. And then we also have the young patients. We must not forget them. So we are seeing right now erectile dysfunction in 20-year-olds that we used to see in 40-year-olds. So there's a huge wave of young men with erectile dysfunction. And in my opinion, this very much has to do with psychogenic processes. So there is no, in most of them, there's no objective reason why this should be difficult, because the hardware is intact. There's no hormonal issue. There's no such thing as the corpora of the penis. They are young. They're, so to speak, they are fresh. Why shouldn't they work? And I have a lot of patients who have been diagnosed with venous leakage in this age group, and I'm kind of hesitant to support this because the venous leak, I don't really know what we're dealing with. There's a couple of patient groups where I exactly know what this is. And venous leakage is the classic in prostate cancer. When you get your prostate removed, you don't have any kind of erection for over a year. The penis starts to shrink, it gets smaller, and then it kind of is too small for the surrounding structures that would then close off the veins when the pressure inside is rising. And by the time nerve is firing again, you may get an erection. Then blood enters the penis, and then it immediately runs out again, because there is too little pressure inside, and the corpora have gotten too small, and you have too much fibrosis, which is muscle has become lost due to not being flooded by blood every now and then. And this would be a classic of a venous leak. But I frequently get these questions about veins per se, and I have to say, don't think blood vessels when you think about venous leakage. Think system, because these veins are underneath the tunica albuginea. If you don't know what I'm talking about, my latest video this Wednesday is about penile anatomy. I really recommend that you watch that, because everything that I'm telling you right now is based on this video. And I give you all the structures and also muscle, how it looks like. So tunica albuginea is the structure around the corpora cavernosa. And this is very rigid, so it compresses, compresses the veins when pressure inside is rising, so the veins get compressed. So it has nothing to do with any vein valves or so. And this is why venous surgery is not really working, in my opinion. So all the people I've seen who went for surgery on the veins, they got better for 3 or 6 weeks, and then they got back to square one. So it doesn't really work, because you don't have to think blood vessels, you have to think more in a system and a structure, and how the system works and why blood is running out. So maybe it's that the pressure inside is not high enough, that maybe the tunica albuginea is not doing its job, something like that. But I rarely would say it's a venous problem. I don't find any kind of research on that, and the literature is not very rich in comments on the venous leaks. So it's something that's postulated, and there are lots of patients who went to other doctors and they just get this diagnosis. And I really warn about diagnosing the venous leakage with the injection tests, you know, where you put in an injection like Trimix into the penis, and then you get an erection, and you see what's going on with the blood. It's good for blood inflow, but it's not very good predictor of venous outflow, because there are so many factors that can interfere with the outcome of this test. So I wouldn't be able to make a diagnosis of this, and I'm not doing this either. So I'm just looking at this, see what's happening, and then I never base a diagnosis of this on injection tests. This is merely for looking at what's happening, how's resistance. Like lately I had a patient, very interesting, relatively young man, who had a high resistance within his cavernous bodies, which was well visible. His penis was not erecting, but his curve looked like he was erect. That was very interesting. Stuff like that. So venous leakage is not based on that. What else? Let's have a look at some comments. Great stream. Thank you very much. Yeah, and I was just touching upon the veno-occlusive dysfunction. Do shockwaves really help with veno-occlusive dysfunction? I would like to know your personal experience. So what we have evidence on is that if you have a slight fibrosis of the corpora cavernosa, so if muscle has been lost due to the aging process, shockwaves will restore this muscle. So this will help with the veno-occlusive problems, because then it will enable the pressure to rise more and it will compress the veins. But I'm not quite sure about losing muscle large scale. And sometimes I'm talking about microscopic changes, but sometimes I see macroscopic changes that I can see upon ultrasound. Then you can really see an area within the corpora cavernosa. I have some videos uploaded where you can really see this is a spot that looks altered. So there is a fibrosis, and I'm not quite sure about these spots, whether they will be regenerated by shockwaves. Maybe. I think this is a very early in this kind of research. And I think one has to keep in mind that after all, there are not so many people dealing with sexual medicine, erectile dysfunction in our nowadays world of medicine. A lot is centered around cancer, and a lot of healthcare systems where cancer is the number 1 and number 2 and number 3. It's like I was working in the Scandinavian countries, especially Norway and Sweden. Everything is centered around cancer. So if you want to get some help with erectile dysfunction, it's they don't do that, so to speak. So it's nothing that's prioritized, because all the resources go for cancer and all these very severe diseases, and function is not in the focus of some healthcare systems. So there are not many people dealing with this science-wise and not doing this. I was gonna say something about PRP, because I wasn't ready about this. PRP, there is no consensus how to produce PRP, and this is very important to have in mind. There is maybe a certain threshold where we think that platelet-rich plasma is effective. So I've read something about 1 million platelets per microliter, and the usual concentration is around like 150,000 to 250,000, something like that. So it's 1 million per, I think, or per milliliter. It was per milliliter. So these are the concentrations that maybe are effective. And the question is, how do you get this? And I read a lot of articles about PRP and people who did PRP. And I'm not quite sure whether everybody has the quality of producing PRP. I was looking around quite a lot, and I did some research. And in the beginning, I did send in some samples, and I wasn't satisfied with the results. In some system that I used first, the platelets weren't that much as I wanted them to be. So right now, I have settled onto 2 systems, which is from one company, and there's a special centrifuge which takes 20 minutes to do the PRP. I think this is a very handy system, because there's a lot of stuff that you just throw away afterwards. It's a centrifuge, you put in your material, and you don't get into contact with any blood. It's all closed. It's a closed system. So just take the blood, and then you put it into the bag that's connected to the system, and then it just sucks all the blood in, and it centrifuges it, and you have a syringe that you place at one knob there, and then it all just goes in, and you never touch anything. You have no risk of getting into contact with a potentially infectious fluid. So this is very handy, and this can concentrate platelets in a very high amount. So what I'm getting this 1 million platelets, and then you also have to think about that every patient is different. So not one man has the same amount of platelets, and platelet amount also changes from day to day. All these parameters matter. Plus that what's inside the platelet-rich plasma may also matter. There's lots of unanswered questions. For the time being, the system that I've been talking about also inserts some red cells, because you can't do without in this high concentration. I don't think it matters. What may matter is the fact that it also includes white blood cells. White blood cells are associated to the healing process. So whenever you have a wound, there will be white blood cells, and they will kind of promote an inflammatory process. So wound healing goes via an inflammatory process, and leukocytes, which is the name for white blood cells, they are necessary for wounds to heal. And this system includes white blood cells, but the other system that I have is the same company, and the same amount of platelets that I get, it doesn't include white blood cells. So the question is, what is better? Is it better to have with or without? And for ED, I'm using it with white blood cells, but I've started to treat Peyronie's disease without white blood cells because there is an inflammatory process, and this is just on theoretical grounds, so I have no science to back that up. But in orthopedics, they use platelet-rich plasma a lot without white blood cells, and they see results much faster. And this is one of the unanswered questions and the very exciting questions to answer. What would be better on the long run, with or without? But for the time being, I'm seeing beautiful results with the white blood cells. So another question. Let's see. H-wave therapy. Shockwaves. I have shockwaves in the beginning. H-wave. I have no idea what this is. Greetings back. Okay. So if you are not live and if you're watching this live stream the next days, please remember to subscribe to UroChannel. That would help a lot. Thank you very much, and like this live stream so that it gets distributed to other viewers, and maybe we get new audiences. I think live stream is a challenge because I am speaking without a script, so I have a topic for a live stream, and then I have to come up with some ideas. I think it's very exciting. I like it very much. This is why I will continue to do some live streams, at least for maybe half a year, and then I will evaluate how it's going, because right now there are not so many people watching the live stream, but that might change with time. We'll see. So I will have some topics that were very popular that I will address in my live streams another time. So what is in the pipeline for tomorrow? Tomorrow is going to be very excited. It's a glimpse into the past. And I'm doing a video on Kinsey because I got a lot of comments why I was using Kinsey data in one of my latest videos, 4 weeks ago, I think 4 or 5 weeks ago. Because in lack of any other data, I looked at the Kinsey data and just to come up with some numbers. He was a pioneer, and some of his work still is valid until today. And in this video tomorrow, I'm going to tell you why, and I think it's very interesting. So if you want to watch that, go ahead. It's 2:45 p.m. Central European time. It's going to be released. I thank you very much for watching this live stream, and wherever you are, have a nice evening, have a nice weekend. Here outside in Germany, we have winter time. I had to, with my snow shovel yesterday, I was about 2 hours, and that was very exhausting because we got snow within 2 hours that was this much. But now it's almost gone, so we have the roads are free of snow, and the pavements are free of snow, so one can walk again. But very exciting stuff. So, but also very exhausting. So have a nice weekend. See you next week or tomorrow in